should have listened better. Hello, can you hear me? Hi. I'm here to introduce our speaker today for Grand Rounds, Katie Larson-Nath. Katie is from Minnesota. She attended Carleton College and then got her MD at the University of Minnesota. She was a resident here and a chief resident here, and then she left us and went off to Milwaukee and did her PhD fellowship at the Medical College of Wisconsin. She's returned to run our intestinal rehabilitation program and our intestinal transplant program, and we're delighted to have her talk today.
I can use that one.
Okay.
All right. Well, thank you, Sarah Jane. It's great to be here, and this is a much nicer venue to speak in than the Brennan Center was, doing 3Ms back as a chief. So let's get started. I have nothing to disclose. So intestinal rehabilitation centers around children with intestinal failure. And intestinal failure is a condition that leads to inability to maintain food, energy, and nutrient requirements. It is not just short bowel syndrome, and while that's the most common etiology of intestinal failure, there's a wide variety of things that can lead to intestinal failure. The functional definition for intestinal failure is the need of parenteral nutrition for greater than 6 to 12 weeks, depending on which source you look at. So what are the most common causes? Like I said, short bowel syndrome is definitely the most common cause. It's about 3 to 5 per 100,000 births. Necrotizing enterocolitis is the most common etiology of short bowel syndrome, followed by volvulus and atresias. If you look down at the bottom here, it says multiple diagnoses, and that is going to be children who have potentially gastroschisis and an atresia. So that's going to be your second most common etiology of intestinal failure. Neuromuscular disorders, so these tend to be children who actually have a normal length of gut, except for the Hirschsprung's disease kids, but it does not function properly, and therefore they cannot tolerate feeds or absorb the proper nutrition. Gastroschisis is the most common etiology of this, followed by Hirschsprung's and then pseudo-obstruction. And then the least common etiology is going to be disorders of the enterocytes, and these are going to be things like microvillus inclusion disease, tufting enteropathy, and autoimmune enteropathy. These are very rare, and these children cannot tolerate, most of these children cannot tolerate any enteral nutrition and therefore rely on parenteral nutrition for growth. So the goal of any intestinal rehabilitation program is to promote adaptation of the gut. And adaptation is going to be and this is what allows children to tolerate food and become independent of parenteral nutrition. It is functional, this adaptation is functional changes in the gut, in the small intestine especially, to overcome the intestinal loss that they have had. And that includes cellular hyperplasia, villus hypertrophy, increased crypt death, and increased diameter of the small bowel. How this happens, there are many mediators that contribute to adaptation. One of the biggest ones, though, is enteral nutrition. Others are GLP-2, epidermal growth factor, IGF-1, glutamine, and growth hormone. Now, the schematic down here is a representation from an article on a rat model of short bowel syndrome and adaptation. What they did is they did a jejunal resection on several rats and then provided factors to try and better understand what allows for intestinal adaptation. And so here there's this part representing the resection, and then this first set of rats had just TPN provided. And with that, they had decreased IGF binding protein, which led to decreased IGF-1 expression, and there was not the hyperplasia and the adaptation of the gut. They then gave these rats a GLP-2, and with that, with the addition of the GLP-2, you had increased crypt death, you had depth, and expression of IGF binding protein. And this was potentiated even more with the addition of enteral nutrition, and these rats actually gained more weight and on the same number of calories than the rats who just had the GLP-2. So this further shows how the different factors play a role in intestinal adaptation. So when does adaptation occur? There's actually important timing in adaptation. This here is a graph and representing children and their outcomes when they have short bowel syndrome. So the entry criteria is I should say the x-axis is the time from when they met entry criteria for the study, which was when they were determined to have short bowel syndrome, and the y-axis is the cumulative percentage of patients who still were on parenteral nutrition. This top line here are the children who obtained enteral autonomy. So we're off of PN, they may have been on enteral feeds or taking all food by mouth. And you can see that the majority of this adaptation occurred in the first 2 years after resection. The majority of these children were infants, and it's well known that after 2 years, very little adaptation is going to occur. So those first 2 years are critical for any patient who has short bowel syndrome, and it requires intestinal or adaptation. What factors are related to adaptation? So the diagnosis, children with necrotizing enterocolitis actually have better outcomes than other children. Lower gestational age and increased residual small bowel length, which we will talk about in a couple slides, allow better adaptation. Early introduction of feeds leads to a child being more likely to adapt. Treatment at an intestinal rehabilitation center where there is standardized care is important. And what's interesting is actually treatment in a non-intestinal transplant center led to children being more likely to adapt with transplant-free survival. Now, looking at that study, they did note that the children at the non-intestinal transplant centers did go there later within their disease course and have been treated elsewhere, not even at an intestinal rehabilitation center, and they think that some of that may be a self-selecting population of patients who are sicker. And then having fewer infections and preservation of the ICV, ileocecal valve, are all things that are making a child more likely to adapt. So looking more at the age of time of injury, actually premature infants do better. And that is because your intestines actually double in size in the last trimester. So this study here actually looked at children undergoing laparotomy from premature infants up to 5 years of age. And what they did is that they measured the mesenteric length at the time of surgery and recorded here. And what they found is that at the end of the second trimester, between 24 and 26 weeks, the average small bowel length was around 70 centimeters around here. I should say the x-axis is going to be your post-conception age at surgery, and then the y-axis is the bowel length. So at the end of the second trimester, early third trimester, there's 70 centimeters of bowel, and by term, 39 to 40 weeks, that had doubled to 157 centimeters of intestine. So that is while you have these children who are premature, you'd expect them to have poorer outcomes because of the many complicating factors often associated with the prematurity. They actually do better because their gut has naturally more growth to do. And then you can also see that most of the intestinal growth has finished by 2 years of age, which goes back to that other study of when children were going to be likely to adapt. Intuitively, length of small bowel you would expect to lead towards adaptation. Those with longer length of small bowel when they have short bowel syndrome being more likely to adapt. Here, this is a study looked at 171 children with short bowel syndrome that was diagnosed during the first 6 weeks of life. So these would be premature to term infants. They define short bowel syndrome in this case as less than 50% or less of expected residual bowel length. And so in all three of these figures, the x-axis is the number of days that they were on parenteral nutrition, and the cumulative percent still PN dependent is on the y-axis. This first one here, this dark blue line, is children with 10%, less than 10% of expected bowel length. So that would be a child, premature, early second trimester infant or third trimester infant with 7 to 10 centimeters of intestine, or later on with 15 to 20. And you can see that they're not, there's a significant portion of them out to 6,000 days were still PN dependent. But there's a significant difference between the children with less than 10% and greater than 10%, which is shown here, where the less than 10% is this top line, and the greater 10% is this bottom line here. And out to So even out here, you see that the vast majority of these children are going to adapt. And again, most of this is happening within that first 2 years of life, as this is represented by 1,000 days right here. They also found in this study that the presence of an ileocecal valve led to more children with the ileocecal valve had adaptation, as indicated by this bottom line, compared to those who had lost their ileocecal valve. So in addition to the amount of small bowel remaining impacting your chances of adaptation, you have to think about what part of your small bowel is remaining and how does that affect your chances of adaptation and the things that need to be monitored as you're going through the intestinal rehabilitation process. So any child who has intestinal loss is going to have decreased surface area for absorption, which leads to impairs caloric absorption, may make it harder for them to grow as well because they're not able to get the calories and nutrients they need. They also will have more rapid transit time of what goes in, further impacting their ability to absorb nutrients. And especially early on in the course, they have increased gastric acid production, which has several side effects, including acids. Acid and gastric acid is also a stimulant of motility, again increasing the transit time. And gastric acid can inhibit pancreatic enzyme activity, so if you have increased acid, you're going to have more trouble absorbing your fats. So this diagram here nicely shows what parts nutrients are absorbed in which parts of the GI tract. And we know that children with duodenal resection, which is less common, are going to have more trouble with iron absorption. Looking at the jejunum, you have a lot of things that are absorbed there. So you have your carbohydrates, protein, fats, vitamins, trace elements, and minerals. What's interesting is that jejunal resection is actually better tolerated than ileal resection, and that's because the ileum has the ability to adapt and take over what the jejunum would normally do. When you have ileal resection, you tend to have higher fluid and electrolyte losses. Part of this is because the jejunum just doesn't adapt for the ileum. In addition, zinc loss can be significant, and this becomes a vicious cycle. So when you have decreased zinc, you actually develop more diarrhea, and diarrhea leads to increased zinc loss, and so it compounds on itself through time. You lose your ileal brake, which is a hormonal mechanism that's only somewhat well defined that slows down intestinal transit. You have trouble with loss of bile acid reabsorption and B12 absorption. The ileocecal valve, again, you're going to lose your ileal brake, and then you can have increased small bowel bacterial overgrowth, which we'll talk a little bit more about in a few slides, and how that impacts the many aspects of intestinal rehabilitation and adaptation for these children. And lastly, your colon, you have increased diarrhea due to loss of water and electrolyte reabsorption, which is a significant part of what the colon does. You also lose some caloric absorption. So the bacteria actually ferment carbohydrates to short-chain fatty acids, which can be used as an energy source for the colonic enterocytes. So a little more about small bowel bacterial overgrowth. This is a proliferation of bacteria in the intestine, and this proliferation of bacteria from various endotoxins leads to intestinal inflammation and villous atrophy, which again causes malabsorption. Risk factors include surgical blind loops, so anywhere that the bacteria can stay and hang out is how I think about it. Intestinal dysmotility, again, things aren't moving through, so the bacteria stays there, it's not going through like it should. Stasis from stricture, inflammation, or adhesions, the absence of your ileocecal valve, which kind of is a reservoir, and then malnutrition itself and PPI use all affect the bacterial composition of your intestines. This small bowel bacterial overgrowth leads to feeding intolerance through a couple of mechanisms. One is, that's not listed here actually, is that children can become very distended from the gases that the bacteria produce that leads to some feeding intolerance. You also have deconjugation of bile salts, which will lead to diarrhea. And you have a toxic effect of the bile salts themselves on the enterocytes, which leads to malabsorption of carbohydrates and protein. With this carbohydrate malabsorption, you can actually end up with something called a D-lactic acidosis. These children can come in looking septic. They will have a positive anti-GAP metabolic acidosis, but you will not be able to find necessarily an etiology, and that's because the bacteria create this D-lactic acid as a byproduct, and our serum biomarkers for lactic acid are actually the L-isoform. There are urine studies that can look for this, but the treatment of this, if it is suspected, is to provide antibiotics and rehydration. Severe cases, if not noticed, can lead to have neurological impacts, including ataxia. You can end up with vitamin A, D, and E deficiency. Vitamin K deficiency is less common because the bacteria actually make vitamin K, and you can end up with B12 deficiency as well. And a big thing for a lot of our children with short bowel syndrome and intestinal failure is actually this bacterial translocation and sepsis that can cause from this. And you'll notice that in children, when they come in with a line infection, if they have any sort of intestinal failure, they're often going to see gram-negatives and anaerobes as the cause of your infection. And this is thought to be due mostly to the fact that your gut bacteria are translocating against the wall of the intestines, which are not perfect, and leading to the septic events. Most people will empirically treat for small bowel bacterial overgrowth. You can do an EGD with duodenal aspirates, which is there's debate about how reliable this is. You can also do breath tests, but again, those require cooperation from children, and they're impacted by the diet of the child as well. So many of these things make them impractical in these patients. There are many different antibiotics that are used to treat and prevent small bowel bacterial overgrowth. Some of them are listed here. There's no standard on what is the best. There haven't been studies looking on which antibiotic in this population is the best, and you'll see various combinations of these being used. Probiotics have been shown to reduce symptoms in small bowel bacterial overgrowth, but these have to be used in caution, and I actually avoid using them in children with intestinal failure and short bowel syndrome because there have been cases of, say, lactobacillus sepsis in children who have used probiotics. So the main sustaining factor for these children as you are working on rehabilitating them is going to be parenteral nutrition. And this is a lifesaver, but also is what leads to most of the complications and the morbidity and mortality for these kids. And we'll talk next in the next several slides more about a few of these complications of parenteral nutrition that come up frequently. The first thing we'll discuss is going to be central line associated bloodstream infections, or CLABSI. So CLABSIs occur at 0.8 to 13.8 per 1,000 catheter days, depending on which study you are looking at. 1,000 catheter days is going to be the standard that is used to measure this. So it's each day a child has a central line in is counted as one catheter day. They occur most often, like I alluded to before, from translocation of gut bacteria, which is about going to be 2/3 of these cases, or less likely colonization from skin flora. It's for this reason that it's rare that we will not treat, say, a Staph epi infection in a child with a central line. Complications from this can include sepsis, loss of catheter sites, and since these children are dependent on their catheters for growth, you do have a limited number of vessels, and we become very diligent about trying to work through any sort of infection to maintain as many catheter sites as possible. And you have worsening of parenteral nutrition associated with liver disease. Ways to prevent CLABSI include line bundles. So what line bundles are is, you'll see the nurses on the floor do this all the time. It actually also happens now in home health settings where everything that's needed for a line change, a dressing change is included in one package, so you're not going in and out of the room, which has been shown to dramatically decrease infection or CLABSI rates and have a positive outcome for children. Single lumen catheters are important, and this again is going to be one less site for infection. If you use a double lumen catheter, you have two ways for bacteria to get in instead of the one. And ethanol locks. And we'll talk now a little bit more about ethanol lock prophylactic therapy. So over the last several years, this has become much more standard of care for children with central lines. And what they are is you actually use a 70% ethanol solution, and you dwell anywhere from 2 to 24 hours, depending on the protocol. Most of the time, I will use it from 2 to 6 hours while the child is being cycled off of their parenteral nutrition. The requirements for ethanol locks, including having a silicone line, there's actually increased line breakage if you use a polyurethane line with it and ethanol together, and no heparin, and that's because the ethanol and the heparin together lead to increased clot formation. And while this is starting to become more of the standard of care for these children after they have 1 or 2 line infections, there are still several questions. One is the complications, as there have been recorded. Some people feel that there's increased rates of thrombosis and line breakage with the use of ethanol lock therapy compared to those who are not on ethanol lock therapy. Looking more specifically at the efficacy of ethanol lock therapy. So this study looked at 24 patients, and again, most of these studies that are out there are small studies of not more than 30 patients, especially in the pediatric side. And what they did with this study is they took the children, both a cohort before ethanol, they took their cohort before ethanol lock therapy, and looked at them then after ethanol lock therapy was introduced for these children. They were getting daily ethanol locks on their lines. And so what you can see here in these factors is that the rates of CLABSIs, or here they say CC, so central catheter associated bloodstream infections, per 1,000 catheter days was significantly less. It went from 7 to less than 0.6. In addition, the numbers and the number of new insertions of the central line were significantly improved, and the hospitalizations for fevers were significantly different between the groups. In this small study, the number of catheter repairs, the use of TPA, which is a surrogate for possible clot formation, number of catheter occlusions, and then hospitalizations and duration of these hospitalizations were not significantly different between the groups. So this study shows that, yes, there are decreased rates of infection, and did not seem to indicate increased rates of catheter breakage or clotting or formation of thrombosis with the use of ethanol lock therapy. On the other hand, there's another study. This one was actually looking at 29 children who underwent ethanol lock therapy, and they used the 29 children who underwent therapy, and so this represents that whole group, and they actually did a subset study looking at 13 children comparing before and after initiation of therapy. And so I'm going to focus your attention here, and this is where we can see that there was different findings compared to that other small study. So this part here is looking at the replacements per 1,000 catheter days. So if you look here, this is ethanol lock negative groups, so the children who did not have ethanol lock therapy, or for the 13 kids before they had ethanol lock therapy, you can see that they actually had about 3.8 was the mean number of replacements of catheters due to infections before, and 0.36 after was the mean, although if you look at the median, they are both 0, indicating that this was skewed data. And you can see, but this was significantly different between each other. Look at the mean, but you can also see here that there were significantly more catheter replacements due to mechanical issues. So there's about 1 before therapy and about 5 after therapy, and you can see here that this was most likely more normally distributed, as there was none before and 3.4 after. So this study would lead you to believe that maybe there is something to be said about damaging the lines with ethanol lock therapy, and therefore we need to carefully consider the risks and benefits. What are the risks of multiple infections? Does that have more of an overall risk to these children compared to the multiple line replacements when we're concerned about number of access points and sedation and other things needed for the lines? And I think that we do see this conflicting data. The majority of intestinal rehabilitation centers have made, and including us here, have made ethanol lock therapy the standard of care for children with 1 or 2 shown central line associated bloodstream infections. And this is just one Other study that I thought was interesting to look at, this is actually looking at how frequently do these children need to have ethanol lock therapy. It was done retrospectively, and they actually took advantage of some of our product shortages. So this was done up in Michigan where they had an ethanol shortage. And so children who initially had been on daily ethanol lock therapy because of rationing of the ethanol had to go to less than daily therapy. And looking at this line here, we see that the children when they were on daily ethanol lock therapy had a rate of about 0.68 infections per 1,000 catheter days. And when they went to less than daily therapy, which was for the majority of these children twice weekly administration, for some as weekly administration, they went up to 6.1 infections per 1,000 catheter days, which was definitely a significant difference. This is some of the data behind why we recommend using daily therapy when children are cycled off their TPN if you are going to use ethanol. So PN-associated liver disease is going to be the next big complication. This is probably one of liver disease and liver failure is the leading cause of death in children with intestinal failure. The second leading cause, I should have stated earlier, is actually going to be sepsis. So PN-associated liver disease is a cholestatic liver disease that's secondary to parenteral nutrition. Up to 2/3 of children who have intestinal failure will develop this at some point in their life, in their course of care. Younger children tend to be at more risk. And 25% of children will develop end-stage liver disease. So this is a significant factor and something that we have to watch carefully and try and manage to the best of our abilities. Risk factors, so all components of parenteral nutrition have actually been associated with PN-associated liver disease. Most, I think, effort has been put on the lipid components and the effects, the inflammatory effects of the lipid on the liver, and how the omega-6 fatty acids or soybean oil-based lipids, which are standard lipids used in the United States, lead to potentially worsening liver disease. Prematurity is a risk factor for developing PN-associated liver disease, recurrent episodes of sepsis, and this is because you're going to have the toxins from the bacteria and inflammation there that compound the effects of any of the inflammation from PN. And lack of enteral stimulation has also been shown to increase the risk of PN-associated liver disease. That's one of the reasons that we really harp on having even just 1 ml an hour or 0.5 ml an hour of feeds running through, because there is some protective effect of the liver with that happening. So looking more specifically at at the lipid emulsions and how those affect the liver. So probably everyone in here has heard about omega-vin, which is actually a fish oil or omega-3 fatty acid. And right now it's only available for use with an IND from the FDA in the United States. So how does this impact your bilirubin? How does this affect the cholestasis and the long-term outcomes of these children? There have been several small studies demonstrating these results. So this study here actually took 42 patients with cholestasis and who were on parenteral nutrition for intestinal failure, and a group of 49 historical control cohorts. And so this line here, down here, is the weeks from baseline. Is that the bottom line? Is this bottom line here? Is the weeks from baseline. So that's when they were entered in this study. So for the children who were put onto the fish oil lipid emulsion, that would have been at the time they were started on that. For the historical control, that was defined as when they had 2 direct bilirubins greater than 2. And then their bilirubin was trended along here. So what we see here is that clearly the direct bilirubins, or the cholestasis, as measured by direct bilirubin, improved in the children on the fish oil lipid emulsions compared to this upper line here, which is the children who are on the standard soybean oil lipid emulsions. And you can see here, based on the lipid type, they had reversal of cholestasis was 50% on fish oil compared to 5.6% on soybean oil. And the death rate was 7% on the fish oil compared to 24% on the soybean oil. What's important to note though, is that, and so this is where a lot of the use of the omega-3 fatty acids came to be. What's important to note, though, is the lipid dosing. So that was one big difference between these two groups. Because they were using historical control, the historical soybean oil group had average daily lipid dosing of 1 to 4 grams per kg per day, with seemed the mean to be around 3 grams per kg per day, while the fish oil group had 1 gram per kg per day of lipid dosing. And so that 2 factors were being changed in this study. Unfortunately, there haven't been a ton of large studies, we'll talk about one, that have looked at lipid dosing in this picture for various reasons. So in addition, these children may have a direct bilirubin that resolved, but does that mean that their liver disease has resolved? And so this was done in Omaha. They took 6 children with known fibrosis who had been on fish oil lipid therapy and had previous liver biopsies, and you can see representative liver biopsies picture here on the side with the blue representing fibrosis. So what they found in these 6 children, again, it's a small study, 2 after being discontinued off of the, after being fully enteral for at least a month, 2 children had persistent fibrosis on their liver biopsies, 3 had progressive, so worsening fibrosis, and only 1 had improved fibrosis. They haven't followed these children further out, but there is some indication that even though the direct bilirubin has improved, that not necessarily has the liver fully regenerated, and these children need to be followed further to see what impact this has down the line. So I alluded some at lipid minimization. So this study here looked at 31 children and 31 historical controls, where the 31 children were given 1 gram per kg per day of standard soybean lipid emulsion, and the 31 historical controls had been on the prior standardized dosing for this institution at 3 grams per kg per day. And I should say that the kgs per day for the 31 children who were given the reduced dosage was actually at 2 times per week, which is much less than what we do now. And these children were matched for gestational age and diagnosis and time on parenteral nutrition to try to best match, have similar children, since there's a wide breadth of etiologies of intestinal failure. So what they found here was that in the lipid reduction group that they had resolution of cholestasis in 42% of their patients compared to 10 in historical controls, which was significantly different. They also looked at daily weight gain. So that's one of the big things is, are we reducing lipids, but at what expense is this? So is this expense of their weight gain and their development, which will become a bigger question down the line that we do not have an answer to. But you can see that the daily weight gain was essentially identical between these 2 groups. One big concern had been for, especially with this much of lipid reduction down to 2 days a week, is for essential fatty acid deficiency. These children, so 13 children had been on parenteral nutrition for at least 30 days in this study, and that's the time that they had set to monitor their essential fatty acid status. 8 of these children had mild essential fatty acid deficiency at the strictest definition possible. None of them were symptomatic from it. And all of these children resolved with increased lipid dosing to either 1 gram per kg per day for the majority, or for a couple of the children, they went up to 2 grams per kg per day 3 times a week. So based on, there's also, I should mention that there was a study done that was actually stopped prematurely, trying to look more closely at lipid reduction in dosing, comparing children on the soybean and fish oil, but the 2 children on the soybean did pass away, and therefore the study was stopped prematurely, and they couldn't come up with any conclusive evidence as to which is better. So based on the evidence that we have now, we recommend standard dosing in children with cholestasis of their lipids is still using the soybean oil between 1 gram per kg per day, 7 times a week. This is to prevent essential fatty acid deficiency while maintaining growth and hopefully helping to resolve or to minimize the damage done by the lipids. The big question, as I alluded to before, though, is what are the developmental outcomes of this lipid reduction? You know, fats are essential for brain development, and are we going to see, looking at these children further down the line, poor developmental outcomes? And that's still yet to be determined. Lastly, we're going to look at complications of PN, and we're going to look at micronutrient and vitamin deficiencies. And this goes beyond just a complication of PN, as we'll talk about. So things that we think about with micronutrient deficiencies is going to be dependent on anatomy, as if you remember from a slide earlier in the presentation. You have to be mindful of what PN components when you're thinking about this. So often for children who have cholestasis, because of the toxic effects on the liver of copper and manganese, these will be taken out of their PN or reduced. But deficiencies of copper especially can lead to anemia. They can lead to thrombocytopenia and leukopenia, and so this needs to be carefully monitored, as effects of copper deficiency tend to be more common than the impact of the copper on toxicity to the liver when it's maintained in a normal appropriate range. Product shortages, which seem to be a little bit less of an issue but have been a big issue, especially in PN over the years, and then comorbid disease. So thinking about special considerations for children with cystic fibrosis who may also have pancreatic insufficiency, or children with Crohn's disease who have intestinal inflammation going on. So more specifically about micronutrient deficiencies, we can't just pay attention to these, at the time while on PN. Actually, it's been shown that children are at more risk for micronutrient deficiencies after they're off of PN. This study looked at any child who'd been on PN for more than 90 days, but had had at least a month of being on 100% enteral nutrition. And what they did is they looked at what percentage of these patients retrospectively had different micronutrient deficiencies. So this chart here looks at the children as they're transitioning off of PN onto enteral nutrition, so during that transition phase. During this time, 33% of children had at least one vitamin deficiency, and 80% had at least one mineral deficiency, and 50% had more than one vitamin and or mineral deficiency. What is, I think, part of the reason that intestinal rehabilitation programs are so important is that we actually see worsening of vitamin and mineral deficiencies after they have been off of parenteral nutrition for at least a month. So looking here, the red stars represent the only copper and selenium, which the rates of deficiency improved. But when we look at iron deficiency, anemia, vitamin D deficiency, vitamin E deficiency, and zinc deficiency, those all significantly worsened after the transition off of PN, making it important that even though these children are most likely growing well and are fully enteral, whether that's by tube feeds or eating by mouth, that they are still at risk. And this risk is compounded during periods of increased growth, where it's important to be monitoring them at least yearly, if not more frequently, especially during adolescence and puberty, both for micronutrient deficiencies, but also because some of these children are relatively tenuous and they may be able, during slower periods of growth, be able to maintain their nutrition and continue growing, but have more trouble when they hit those periods of rapid growth. We'll quickly now go through a few kind of things that we think about when we're feeding these children and thoughts behind them. I feel like I sound a little like a broken record. There aren't a lot of great large studies because of the heterogeneity of this population of patients and this relatively small number of them spread out over several centers who have different ways of managing them. So a lot of what we do is somewhat anecdotal or based on very small, low-powered studies. What we do know is that these children tend to have similar energy expenditure but have increased losses and therefore can need 125 to 170% of the enteral calories that a similar child would need. For feeding, what to feed them, breast milk is best, and children tend to do better on that. Then after that, actually elemental formula seems to be better tolerated. The reasons why are not completely understood. A lot of these children do develop a cow's milk protein intolerance or allergy down the line, and many of them cannot tolerate cow's milk protein even further down the line, and whether that's not being sensitized early in life to the cow's milk protein because they're put on elemental formula, or for another factor, it's unknown. Hydrolysate and a standard cow's milk-based formula are not well tolerated. And I think it's important to know that in this category, we're talking mostly about the infants. We're talking about infants here. If there's a child, an older child who has had a volvulus, they have no reason to not tolerate a standard cow's milk-based formula or a general cow's milk, a Pediatrics or something like that. And so those can be tried first in that patient population. Continuous feeding leads to better weight gain and nutrient absorption. I think this is where we lack. We would love there to be greater data on this. There is one small study from the early 80s that showed this, and I think it was 3 patients with short bowel syndrome where they actually looked at their weight gain and saw that when they were on continuous feeding, they did better than when they were on bolus feeding. And the goal for us is to protect the liver, because since that is the main reason for morbidity and mortality in these patients leading to transplantation. And the best way that we have to do that while minimizing infections is also getting them off of parenteral nutrition, and therefore rapidly getting them to be enteral tolerant is very important. And while we all want every child to PO, not have an oral aversion, we don't want these children to be taking their nutrition by mouth if that leads to more dumping of formula, more intolerance of formula, as that may prolong their need or time on parenteral nutrition. So I think that's an important thing, is that we really, our goal is to get them off of the parenteral nutrition. When you do think about doing PO, the volume should be limited to start with at least to 1 hour's worth of feed. So if the child's on 2 meals an hour, that means 2 meals of PO, and you should stop the feeds at that time to allow for better tolerance. It's great when we can get them to the point where they're tolerating continuous feeds overnight and then maybe allowing them to PO on a regular schedule during the day. But again, that PO should not be done at the expense of delaying their wean off of parenteral nutrition. So a little bit more about what they should be fed. So complex carbohydrates are better tolerated than simple sugars, so things like fructose, glucose, and lactose. And you have to be mindful of sugars and medications. So a lot of the liquid formulations actually, to make them taste better, will have some sugar in them. In fact, Imodium, the commercial brand of Imodium, has some sorbitol in it, which kind of works against it in some of these kids who are more tenuous. If you give them a liquid Imodium, it actually can make their output worse. And so you can actually crush Imodium tablets and dissolve them in water, which is better tolerated by some patients. For children with an intact colon, you can consider adding soluble fiber. This has a couple effects. One, it slows gastric emptying. And then, as I alluded to before, it allows for short-chain fatty acid formation from bacteria. And this is a colonocyte enterosource. And it also will stimulate sodium and water reabsorption, hopefully by improving some of the diarrhea output. Sodium is a big issue in these kids, and I think you lose both sodium and water together through much of the intestine. And we know that children who are total body sodium deplete actually don't grow as well. And you're going to see a decreased urine sodium long before you'll see a decreased serum sodium. So if you have a child who's not growing well, checking a urine sodium, and if it's less than 20, giving them extra supplementation can sometimes put them over the edge to show better growth. So multidisciplinary care teams. These are teams that are put together to care for these children since they do have so many complex needs in various realms of medicine. They often will include a pediatric gastroenterologist, a pediatric surgeon, a transplant surgeon if this is a transplant, if the child's at a transplant center, although that's not a requirement to have an intestinal rehabilitation team. A dietitian, a nurse, a social worker, child life, OT, PT, and speech are all critical to these teams. These teams, what they provide is a standardized protocol for feeds, for parental nutrition, for monitoring of their nutritional status, for management and prevention of PN-associated liver disease, for treatment of bacterial overgrowth, when the timing of and the appropriateness of bowel lengthening procedures, and for referral for transplantation. This is a meta-analysis of about 5 studies looking at the implementation of intestinal rehabilitation teams. And what we can see here is that there's a significantly overall survival for these children if they're being cared for at a center with a formalized intestinal rehabilitation team is better. There is less liver failure developed, although it does cross the 0 point, and similar chances of developing enteral autonomy. And as might be expected, because these children are being cared for somewhere that this can be done, rates of intestinal transplantation are higher in children who are cared for by intestinal rehabilitation teams. In addition, there's a significant difference in septic events. looking overall through these many studies, going from 0.3 compared to 0.5 per month in children who weren't at an intestinal rehabilitation center. We'll quickly talk about surgical interventions for these kids. So children with short gut, the main intervention available is going to be called the serial transverse enteroplasty or SEP procedure. And once this is done, 31 to 50% of children do develop, it can push them over the edge to developing enteral autonomy. What you need for this is actually a dilated area that's poorly motile most of the time of small bowel, small intestine. And they take that dilated area and put staples in along the edge like this. And so you go from a lumen that's just one straight line along here to more of a zigzag. And so if you think the length of that is going to be longer, you're going to have more area for absorption of nutrients. And that has shown to be very helpful for allowing for intestinal adaptation in some children who are proper candidates. But again, that's why you need to work closely with your surgeons and the other members of the team to make sure that you're doing this on the proper candidate. And as a last resort, there is always intestinal transplantation, either with the liver or without. So there are indications for referral. These are not indications for transplant, but when a patient should be seen and considered for possible need of transplant in the future. These indications include recurrent life-threatening septic events. If they've lost more than 50% of their central access sites, again, because you're going to need central access after transplantation, and that can be a limiting factor for many of these children if they're dependent on parenteral nutrition. Liver dysfunction or failure, direct bilirubin of greater than 2 is often when children thought to be sent for referral. And congenital intractable mucosal disorders, so those are going to be things like a microvillus inclusion disease, where the only curative, these children without transplantation will never be able to tolerate anything enterally. And so that is their only option. And for those children, it becomes more of a timing issue of when are they doing bad enough that it's worthwhile considering an intestinal transplantation, but aren't so sick that they aren't a candidate anymore for that transplantation. And then intestinal failure with poor quality of life and high morbidity. And this is going to be mostly your kids with chronic intestinal pseudo-obstruction who end up parenteral nutrition dependent. They don't as often get the liver disease because they tend to tolerate some feeds early in life, but with time end up on more parenteral nutrition, have a lot of problems with pain and other complications of having a chronic disease. So survival for intestinal transplantations has improved. 1 and 3-year survival rates between 2004 and 2009 are 80% to 65 to 84%, depending on the study. And then between 1994 and 2003, they were much lower at 60 to 45% at 1 and 3 years. But this is definitely not a route to go. It's very complicated to manage a patient after intestinal transplantation. They need frequent endoscopies. Many of them are still parenteral nutrition dependent for some time. And avoiding this if at all possible is what we want to do, and that's the goal of an intestinal rehabilitation program. So what's the future? So lipid emulsions, we talked a little bit about fish oil-based emulsions. Omega-Ven is the one that's known. This is only available with an IND from the FDA, and then you have to have an insurance company that will pay for it. Medicare, Medicaid does not pay for it. There are only some private insurance companies that will pay for it, and this is one of the main reasons that this is not an option for many children with PN-associated liver disease. And for many children, we can manage them without using this type of lipid emulsion with the other techniques that I previously discussed. There is SMOF lipid emulsions, which are actually being used more up in Canada right now, and they're also approved in Europe. Many of the pediatric centers in Canada are using SMOF, which is a combination of soy oil, medium-chain triglycerides, olive oil, and fish oil, thought to provide a better variety of different lipids. And then there is GLP-2 analog, so this is teglutide, is the name of this drug. And if you remember all the way back to the beginning of the presentation, we talked about how GLP-2 actually stimulates enterocyte growth and crypt hyperplasia. And this is approved for use in adults with short bowel syndrome. There was a recent study done at 14 centers, pediatric centers in the US. It was a 2-week efficacy trial that was presented at Clinical Nutrition Week this year that showed that those children actually had significant increase in their caloric tolerance just with a couple weeks of the teglutide therapy. Unfortunately, it's still not approved for kids, and so those children had to stop the therapy after the trial was over. So in conclusion, intestinal failure can result from multiple different etiologies. Adaptation is the goal of any intestinal rehabilitation and is impacted by the function of the remaining intestine, the site of the remaining intestine, and the prevention of complications. Careful attention needs to be paid to micronutrient and vitamin status, including after weaning to enteral nutrition. And improved outcomes are noted with multidisciplinary intestinal rehabilitation teams, and outcomes of transplantation are improving. So this is members of our intestinal rehabilitation team here, and I'm happy to take any questions. Thank you all for listening.
You have been